Hello, nurses. This is Kevin with Nursing KAMP.com, and these are my scribble notes on nursing and the NCLEX. Today's focus is going to be on preload. And this sticky note found on nursingkamp.com, Instagram, Pinterest, Etsy, and I'm forgetting one, Facebook. There you go. All right, let's get started. We got a lot to cover with this. Preload. So the big thing about preload is when we're thinking about preload, it's be the load before the heart. So it's everything that is going into the heart during diastolic. So what I like to think about is like these trucks, and these trucks are basically bringing fluid into the heart. And when it starts to bring this fluid into the heart, anything that's going to affect this preload, like meds like Lasix and nitro. So the same things that we use to treat increased preload can cause a decreased preload. So that's good because we memorize medications as far as like, the landfill, right? Lasix and nitro. And then we get from there. Okay, all right, so let's get into it. So let's talk about the causes. All right, so mitral AFib. So AFib is the atria is not really firing. So you don't have any contraction from the P wave. And so there's no pressure going into that ventricle. And that's called atrial kick. And atrial kick, if there's no atrial kick, then therefore the heart is going to not have Starling's law. And Starling's law is from basic physiology where the greater the fill, the greater the pump or output. So if there's not enough fluid going in, or blood, then there's not going to be enough output. Okay, next thing. Mitral or tricuspid valve problems. Well, it's the same thing with what atrial fibrillation is over here, because if there's not enough Starling's law by snapping closed, like these valves snapping closed back and forth, you can't get the pressure into the heart, so you can't get a cardiac output. So anything that's going to affect the heart, like valves, tricuspid, and the mitral specifically, atrial, into the ventricles. And AFib, right, because it's not really pushing fluid, blood, into the heart. All right, what else? Stenosis, trauma. Well, trauma is a direct relationship to not enough fluid. Infection, like sepsis, also not enough fluid. And then dehydration, so the patient will be orthostatic. All right, so what does it look like? Well, that patient will first see decreased urinary output. So 20, 10, right? So 20 changes systolic, 20 changes diastolic, and heart rate changes 10. So orthostatics is from another lecture. If you saw that, they lay first, then they sit up, and then they will. We look for changes, 20, 20, 10, and then they stand up. Okay. If they are dry and there's not enough fluid, they're going to be affected, or they're septic, or these other causes. However, somebody with AFib or mitral regurg or mitral or tricuspid problems, this will be chronic over time, so they're going to have syncopal episodes. Okay, where they'll be getting up and falling down. It's because there's a problem in the preload that is chronic over time. All right, so we talked about urine output. Urine output we could see by our BUN and creatinine. So those are our kidney labs. So the BUN would be elevated first, and then if the creatinine was normal, they're probably dry. However, if the BUN is elevated and the creatinine is also elevated, then we question, is this an acute problem? Like medications, Lasix, that cause a decreased preload, nitro? Or is it a chronic problem? And a chronic problem would be chronic kidney disease. Okay, which wouldn't be the problem of decreased preload. It would be the problem of increased preload. All right, next step. What's some hemodynamic measurements? We'll cover those at the end. But the next thing is increased preload. So what increases? So I have this picture here. And there's a lot of trucks, a lot of fluid, a lot of blood volume coming in. And they're coming into the heart. And that's a problem because the patient can't accommodate this volume of blood. So on this filling station, they fill up, and you start to see the fluid starts to go elsewhere. Okay, so the plasma, 55. Plasma actually starts to seep out, so you start to see shortness of breath. You'll see edema, depending on which side. You're going to see CHF symptoms, right and left, and fluid overload. Okay, so what do we do? How do we treat? Well, you see this V right here, so there's V's right here, so we vasodilate. And the reason we vasodilate is because of, remember, the fluid is filled, but if we vasodilate, the fluid can go down, and the heart won't be working as hard. So the same things that we do that could cause it, like, the land, okay, Lasix, and nitro, that's what we'll do to treat it. Because the nitro will vasodilate, however, the Lasix will deal with the actual fluid problem. So they're kind of used together. What's some causes of this? Other than medications, CHF could be a cause. Also, aortic and pulmonic stenosis. So when you're looking at the heart, we're looking at the heart, we're looking at these valves. But now we're looking at the aortic and pulmonic, these valves. These tend to be more in relation to preload, increasing it. And that's because the fluid going out. All right. And we'll talk about afterload in another lecture. Okay, so what else do we need to know? Well, with this, the goal is to get rid of the fluid. So we need to get rid of the fluid. And like I said, we treat with nitro, we give a Lasix, we give other vasodilators. All right, so in the end, a normal preload, and let's talk about hemodynamics really quickly. A normal preload, we have hemodynamics and CVP, see the volume peripherally. Okay, that's like your edema, right-sided. And that is generally 4 to 8. And then cardiac output. Cardiac output, if it is decreased, we're going to have less than 8. So cardiac output is also 4 to 8. See my lecture on cardiac output as far as memorization of that. But they're equal. Okay, so it's going to be less than and decreased. And it's going to be, what else do we have? We have ejection fraction. So EF. Now, EF is also like cardiac output, and that needs to be greater than 60. However, with less volume, it's going to be less than. What else? Heart rate. Heart rate will normally always go up because it's a normal process, and the heart rate is trying to treat this deficit. So heart rate will go up. Mean arterial pressure, the DDS, right? So, and when we talk about mean arterial pressure, we're talking about perfusion. And if there's not enough fluid, or there's too much, it's going to decrease mean arterial pressure, less than 60. The brain needs 70 to 75 on a mean arterial pressure. And that's why decreased level of consciousness and restlessness is always acute and comes first. Because when that mean arterial pressure is not perfusion, there's a problem. Okay, what other hemodynamics do we have? We have stroke volume. We'll cover it in another lecture. And we have wedge pressures, the final one. Wedge pressures are, we said CVP is 4 to 8. I usually add these two together. I get 12 into 8 is a pulse wedge pressure. Well, wedge pressure is where CVP is left atrium. Right atrium. Wedge pressure is left atrium and more towards the lungs. Well, that's a basic overview of preload, decrease versus increase. It's mainly a concept for NCLEX, the underlying cause, but not so much the memorization of it, because we see this threaded throughout, and it's all about perfusion. My name is Camp, and this is Nursing KAMP.com. I'm covering cardiac this month, and these videos are. See my next video on afterload. You can find me on Instagram, Facebook, Pinterest, and Etsy, and nursingkamp.com. We'll see you next time. Thanks.